This could potentially be like the worst. This could be the very worst live I ever do because I am so frazzled at the moment. I have a studio microphone that can't find the stupid connector. So I'm kind of SOL right now with that. And I'm fixing this light right now and it doesn't want to move. So yeah, I'm having a few technical difficulties, but I wanted to like pop on here anyways and get some things started. So, welcome to my live stream. If you are here tonight and you are coming in from anywhere in the country or across the world, welcome. I'll try to take my glasses off so I don't have so much of a glare, but I am a little bit blind, so it might be a little difficult. I am coming on here tonight as kind of a test. I wanted to get on here and see if I could connect with some nurses out there, mostly, ER nurses. I am an ER nurse by specialty. I have been an ER nurse for 22 years as a nurse. Most of my care has been in intensive care and in the ER most recently, and in the last, 15 years or so. I started in the surgical ICU and I got my seasoning there, and then I worked my way on back into the ER actually, because I started there long before I became a nurse. I started there. So try to rearrange just a smidgen because this is really sucky lighting and I don't like this, but we're going to go with it anyway. I've got 0 people in here and that is okay with me. So we're just going to keep going. I wanted to do this live stream kind of as a test because I feel like it's great if I can actually connect to people that are out there right now and we could have a conversation. I kind of want to just talk about the ER. If you're new and wanting to go into the ER, don't be scared. The nurses there aren't anyone to be afraid of. They might act like it, but we're not. We're gentle. And if they're like me, I really am vested in training new nurses because new nurses are they're the future generation. They are going to be who comes in and saves our asses. Oh, pardon me. Yeah, there might be a little cursing on this channel because this is my tube, and sometimes we ER nurses kind of have a potty mouth. So I hope you don't mind. So let's just start like you're not an ER nurse and you want to be an ER nurse. My advice anytime anyone asks me, how do I get into the ER? It's so hard to get in the ER. I can't get into a program. Yes, that has typically been the way it has been. And I know that it can be really hard to get into the ER in some places, but you may have to start somewhere. If you're not currently doing hospital nursing, I would encourage you to do that and get into a floor anywhere. Doesn't matter where it is, just get in anywhere. Get working. That's the most important thing after school. If you got through school and you passed your NCLEXs and you did all that stuff, you did the work. Like get making some coin out there because you need to start getting some, footing because school takes forever and you go poor while you're in school. I know how that goes. Pardon me. I do have to sip on a water here in between because I'm a little bit parched. What I tell people who ask me how to kind of break into the ER, if you're at a hospital that does a very prestigious ER new grad program, yeah, you're going to have to apply and you're going to have some really good street credibility in order to get yourself in there, unless you know someone, which I hate to say it, that whole it's who you know, that can be that way sometimes. But the truth of the matter is anybody who's doing the hiring or bringing nurses in, I have done the hiring myself in the past. And I just want to know that the nurses coming in are willing, ready, and able to work. I hope that my mic is on. I need to double check this real quick as we go along here because if I find out that I am streaming and this is not recording, I will lose it. So give me one moment while I check my connection, and it looks like I am connected right now. Let's pray. Anyway, if I do this whole stream and it doesn't work out, then I guess I can delete it and we can start over. Anyway, like I was saying, if you can get into anywhere in the hospital, med surg, PACU, ICU would be great because I feel like ICU is a place that although the ICU and the ER type of mentality are very different, they do kind of back to back in the way that they have some necessity that coexists between them. Um, Learning your systems assessments, your drugs that you use in the intensive care unit, the procedures that can go on are very, very important because some of those procedures are done on the fly in the ER. Now, here's what I have to say about that. If you get your foot in the door into med surg and you want to go into the ER, I'm going to tell you right now, I'm sure at some point in time you have been asked to float or you will be asked to float. Float. Don't be afraid. Float. Volunteer to float. Get yourself down there. Let people get to know who you are. When you go down there, they're not going to throw you to the wolves. No, like cognizant, smart, decent charge nurse is going to tell you you need to take care of the highest acuity patients. They're typically going to be happy to just have an extra warm bodied, able bodied, licensed nurse down there to help back them out of a jam because usually the ERs are overflowing. They need help. Go down there and do whatever they need you to do. Ask them, what can I do? And just find things to do. You just start making yourself useful and you will learn a lot just in the time that you float there. But like I said, people act like when they go to the ER that they're being thrown to the wolves, and that's not how it is. Not where I've been, and I've been in several ERs all through Southern California from very high acuity to small community ERs. If you're floating to the ER, have a conversation with the house supervisor before you go. Hey, I'm not experienced. I'm willing to go. Just want to make sure that I'm not put in a situation I'm uncomfortable with. Let the charge nurse know, and hey, she'll say, hey, or he will say, hey, I got you. Thank you for coming. And let's put you over here with this, and this patient. I'm sure they can find patients that are the acuity that you know. Now, here's the key. They're probably not going to throw you out into triage because usually they have someone who's a little more experienced or knows the software on triage out there. If you have to triage, all you need to remember is think about what you know, your systems, chest pains, and anything with neurological deficits are going straight back. If you need help with it, ask for help. Always ask for help. There is no shame in asking for help. Asking for help is like, I find it a lot easier to work together with a nurse who will ask for help versus someone who won't ask for help and then get themselves into a pickle an hour in finding out that they had no idea what to do in the first place. Most good charge nurses are going to help you along. They're going to show you what to do, or they're going to give you tasks. And if you don't know how to do it, they're going to help you learn how to do it. They really just need people to be willing and able to float down there. And the more that you're willing to do that, your name will become a name that comes up in the emergency department. And more than likely, when it comes time to be asking for jobs or asking for a foot in the door, they're more likely to take you over someone they don't know. If you've been willing to go in and you've been willing to help out where needed, you're going to be the first one in the door when it comes time for hiring. That's how I did it. That's how a lot of nurses I know did it. I worked in the ER as a tech for a number of years. Then I went to ICU for three and a half years or so. Like I said, by the time I left ICU, I could probably have gone anywhere at that point, but I wasn't. I had been in the ER, I understood the flow, but I wasn't a ER treat and street kind of nurse. I had gotten all of the systems things down. So it took me a bit to adjust back over from the whole patient to focused assessments and dealing with the problem at hand. So it's really important that you understand that. You'll learn it as you go. ER is not magic. It is something that it's a skill. And just like when you came out of school and you learned the skill of taking care of patients on the floor, you're going to learn the skill of the kinds of patients that come into the ER. Most of the patients that come into ER are not trauma. They're not, there are those, trust me, there are traumas and there are strokes and there are heart attacks and there are aneurysms rupturing and there's crazy stuff. Typically, that is not what you're going to have as your first patient in the ER. If you're so lucky as to have that as your first patient in the ER, I guarantee you there will be some kind of a resource person there with you helping you through it because it's a team environment. People help each other out. Nobody's on their own 100% in the ER. If they are, there's a problem. And if you're ever put in a situation you're uncomfortable in, and speak up, let someone know, hey, I've never done this before. I'm not comfortable. I either need someone to show me or stand by me or teach me how or take me out of the situation, have someone else do it. It's just the way it is. They'll have more respect for you if you do that than if you just, play the silent, silent and don't know, and then crisis brews because you didn't know what to do. So if you've got some courage in you, like do something scary, float to a unit you're not comfortable with, more than likely the unit that you're there in is going to be more than appreciative to have you there. So just do it. It's not that bad. That's what I have to say anyway. Um, Triage is all about focused assessment. Understand that most of the things the patients come in for are not true cataclysmic emergency. It's important to be able to identify things quickly, and triage is an art form, and it does take a while to get it down and get it down quickly and understand what you're doing, assess, you get to a point too as a nurse after you've been doing triage and ER for a long time, you can see someone across the room and you know that they're not good. They walk in that door, their color is off, and you can just tell they're a cardiac patient walking in the door and they need to be triaged immediately. You get a feel for that. And sometimes you miss some and sometimes you don't. So it's hit and miss, but at the end of the day, as long as everybody receives adequate care and in a timely fashion and the process goes as smoothly as possible. And the one thing that you'll find about ER nurses is they are very flexible because we know that there's no cookbook to work out of. It's not like in the ICU where I call it cookbook medicine. If this, then this, if this, then this. It is like that in the ER, but it's a different sequence of events. And the gray areas can be a lot more undefined, if you want to say. Undefined, yeah. Um, Depending on the facility that you work in, some will not allow conscious sedation to be done in the ER for certain kinds of procedures, and some will allow it to happen, depending on their relationship with the doctor and what's going on. I know that in the past, it used to be everything that could be done would be done in the ER, all the reductions, all the hips, all the whatevers. Sometimes now they're taking them to ORs. I've heard that that's a newer trend. I haven't seen it as much, but I've heard that's happening more. Probably is a good idea because some of these closed reductions we're doing under conscious sedation, they've been down with their hip dislocated for 12 hours. They're not going in very easily, and it's a much more resource sucking type of event because it's going to take a lot more effort to get that hip back in, and that would probably benefit by being fully anesthetized with an anesthesia doctor and airway. So yeah, we can do those things, but there's certain things that depending on the amount of resource it's going to take and the staff we have at a given time, we're going to try to defer those to other departments. Cardiac cath labs are going to come into the ER, get assessed, diagnosed, and they're going to go straight to cath lab if they can be. Let's just talk about chest pains because those are the biggies. Chest pains and neurological or stroke protocols. Outside of all of the other stuff, you're going to see a lot of diabetes, a lot of alcohol-related issues that people come in with an inflammation or exacerbation of a condition related to something that just so happened to be going on because, say, they were at Halloween tonight and they drank a ton and they have esophageal varices or they have a liver that's inflamed or they have pancreatitis and all of a sudden they're coming in because system overload. It happens all the time. And we have to manage those as they come. But when it comes to things like chest pain, I want you to remember these two things about the heart and the brain. Those are the two organs in the body that do not regenerate brain cells or heart cells when you have cellular death. Two organs in the body that do not regenerate once cellular death, I'm spitting in my words, sorry, cellular death has occurred. And I'll explain why. The stem cells in those organs are not regenerative. When you have brain cells that are blocked from oxygen, blood flow or glucose in the brain, the cells start to die. And you can actually see on scans where those regions lost, they lost perfusion, oxygen, nutrients, or whatever, and later the damage is done. If a patient's coming in and has a side facial droop or is completely altered, or they have a complete one side of their body droop, or just even the smallest little thing that, if even if it looks like a Bell's palsy, don't just rule it out. We need to check it out fully. The first thing you do is, you need to find out when did it start? Because these are time sensitive issues. When did it begin? Because that delineates the treatment protocol for the doctor. When did it start? What happened before? Was there a precipitating event? Did they get hit in the head? Was there something going on, or were they just waking up like this, or were sitting at the table and all of a sudden it occurred? Um, you want to know those things, and then immediately you want to check a blood glucose, always. A diabetic patient who has hypoglycemia can manifest and look like a stroke patient. Oftentimes, the symptoms look identical. The first thing you always check for is the blood sugar, because someone with very low blood sugar, it looks like they're having a stroke, and that can be fixed really quickly. And if a brain is without sugar for long enough, it can start to die, just as if it were without oxygen or had an occlusion, whether it be some kind of fat occlusion or, blood, bleeding in the brain and not getting perfusion to that part of the brain. Very similar, because without the nutrients, the brain starts to die. So a hypoglycemic patient can become a life-threatening issue very quickly. With the heart, same thing applies. If a patient is truly having a heart attack, if they're having a aneurysm that is either leaking or ruptured, obviously ruptured, you're going to know like real quick, because their color is going to be, they're circling the drain, they don't have pressures, things are going badly really fast, and you have minutes to try to intervene on that. But it's also important to try to identify whether this is an exacerbated type of chest pain event. Do they have a history? Are they on medications? What were they doing at the time that it came on? Always ask if their activity was precipitated by sex-enhancing drugs such as Cialis, performance drugs, Cialis, Viagra, and not just the men anymore, because we found that some women do take these drugs too, and they do cause severe vasoconstriction, which can cause lack of blood flow to the heart, and those drugs can be longer acting. So we just want to know right away, can they have they had this? Because it's also going to determine what they can't have as part of their treatment that would be the normal chest pain protocol. So you want to know when it happened, how long it's been going on, what they were doing at the time that it happened, age, pertinent factors, risk factors, and medications that they're on. You need to get that real fast, like within a minute, and get them on an EKG and determine what's happening. If you ever have a patient who's having penetrating pain that goes from the substernal chest area that radiates to their back on one side or the other. Doesn't have to be on the other side. It can be straight back and it feels like it's going through to their spine. That is a sure sign you need to assess blood pressures on both arms within a distance of no less than 3 to 5 minutes apart on each arm. When that occurs and you see pulse pressures greater than 20, one arm versus the other, you need to ding, ding, ding. This could be an aneurysm. May not be blown yet, but it definitely could be an aneurysm, and the doctor will probably determine that the patient needs a CT scan right away, or a CT angio. So those are conversations that you can have really quickly without delaying care. So get the EKG right away, get the history, get the meds, get all that you can, and get that patient in the back and get things cooking. IV labs, EKG, and get things moving right away. If the patient is really struggling, you want to get them on oxygen and talk to the doctor about how you're going to, oxygen versus no oxygen. But usually they want them on oxygen if they're suspecting a heart attack, because once the cells around that section of the heart that are being impaired begin to die, they can be forever lost, which could mean that the patient will suffer with an impaired section of the heart, which will lead to congestive heart failure for life after that. Once that heart is damaged in a larger portion of the muscle, that pump becomes damaged and it will no longer pump effectively. So it's important to stop that damage from occurring as quickly as possible and intervene as quickly as you can. I don't have anybody in the chat, which would be nice to have someone in the chat, but I don't. So I'm just going to keep chatting along, because I don't know what you want to hear from me. Maybe someone else will catch up on this video and they'll realize, hey, she was on live. but I'm always open to questions. The thread will remain open, and I will still respond to questions even after we're done here. It is Halloween, so I hope that everybody out there is safe and having a good time within reason. If you have to go to work tomorrow, hopefully you're not getting too hammered out there tonight. You know what I mean? And if you are at work tonight, hopefully you're having one of those really nice, peaceful times in the ER where you can have a little potluck and it's just we don't say the Q word ever. I won't say it on here. That would be a very foul thing to say, and we don't wish it upon anybody. So we hope everybody on Halloween is having a nice night at work, and anybody who's off work is going to be well rested and not hungover tomorrow. If you are out partying and things get going, I just want to say this. One of my experiences, it's just brought back a memory as I was thinking about it, about Halloween. I worked one year where there was a party going on within a few blocks from the hospital. It just so happens it was a nurse from our sister hospital across town who was at this party with a bunch of other nurses. And there was some really excessive drinking. I don't know what else, but a little something, something else. And, they were at a party and no big deal. They're doing their own thing. They're on their off time. Who cares? But what became a problem is you have to remember at all times, especially when you live in a community you work in, and even if you don't, when you're a registered nurse, you are held to certain code of conduct type of stuff. And it doesn't just pertain to when you're on duty in the hospital. If you do something out in public, like you get a drunken disorderly, or you get in a vehicle and drive while you were drunk, those kinds of decisions can have very lasting impacts on you later, and they can affect your license. We did have a young lady who at this party got into a fight with a young lady and a ex-boyfriend, some kind of triangle fight going on. Things got very loud. The neighbors called the police, and she decided that rather than stay there in her inebriated state, in full costume, I might add, very full, thigh highs, very sexy costume, she got on a GoPed and took off and crashed it halfway down the street when the police were pulling up. So they picked her up. They arrested her. Yeah, she's a nurse. They all know each other. This cop didn't know her, and they brought her into our ER. And apparently the girl she was fighting knew somebody else that we work with, and there was a whole lot of nasty back and forth, which was really unfortunate because although this woman was on private property, she did drive the scooter off to the end of the street, and I believe that she did have an injury. And on top of that, she did get out of the DUI charge. The police officer didn't feel that was necessary at that time and assessed her and said, no, we're not gonna charge you. But he did charge her with a lesser something or other. It wasn't driving, but it was a disorderly. So what ended up happening was the nurse at the hospital I was working at immediately got on that computer and she filed a complaint with the board, which I'm going to tell you, stay out of it with the board. Look, the board gets all kinds of stuff all the time, but just because you're pissed at someone, you really want to stay out of those kinds of things because you can ruin someone's career over something minor. This is something that had nothing to do with patient care, had nothing to do with anyone else getting injured. This is something someone did that was a dumb decision in a heat of a moment, and now somebody's sending it off to the board to review them for God knows what. And this poor young woman ended up having to face discipline for conduct unbecoming of a nurse while out in public. She was horrified. She got fined and she had to go to a program. They made her go to a drug and alcohol program. She was very horrified over what happened. But, just remember that your actions out there, the board always finds out some way or another. And whenever that happens, they're coming for your license. It's just what they do. And it takes a long time to fight to get it back in good standing. So just be careful out there. Get an Uber. There's no need to be driving yourself if you're out drinking. Have fun. And maybe if you see this on here and you're interested in maybe another live, we can get on and schedule something that's more focused as to actually exactly what we're talking about, because I would love to be able to have some conversations with people on here, and I want to know what you want to hear from me. That is what's really important to me, is what can I offer to you as a nurse? I want to build a community of support with one another. I want to support young nurses coming up in the field. I want to find some other nurses who are willing to come on here and talk with me about, some of the mentorship things that we can be doing to make the practice better, and put our heads together, because there's so many problems in everyday nursing that we face together. And I would like to be able to have some really good conversations with my fellow colleagues. I think it would be awesome. So I know this was just a completely ratchet live tonight. I was missing my microphone connector that went into here, that went into my computer, because I have this beautiful studio microphone that you're not hearing it on. You're hearing it on my earbuds for tonight. So I hope the sound is okay. I just want to keep welcome you all back. This is really near and dear to my heart. I am going to keep pushing out as much content as I can. I am still new at this. I am like that baby deer in the snow. I'm just like slipping and sliding, trying to find my footing and figure out how we're going to do this program. But I have this vision in my head of what I want this channel to be. And I am hell bent on getting to my 1,000 subscriber mark by the end of the year. I want to say by the end of the month. I think I can do it. It's going to take a lot of work to get out there, but part of it's going to be live streams, more videos, more shorts, more TikToks, more Instagrams, more Twitters. I'm just going to have to like 10x everything. So that's what I'm going to try to do. But it's not just going to be like a barrage of crap content. I have things planned that I really want to talk about with my fellow nurses, and I hope that you'll want to learn, because there's so much to learn. And I feel like if we stay in this kind of ideal of continued learning, that we can only help ourselves and help each other. And that's what this is about. It's not always about like, when we need help, someone else put a hand out for us. And we have to do that for these nurses that came in during COVID, which was a total shit show. And they came out at a time that disheartened a lot of people, where they wanted to leave the field before they even got into it. And we need to show them a better practice. We need to show them what the sisterhood is all about. We need to mentor. We need to love one another. We need to be kind to one another. We need to be empathetic to one another. That doesn't mean just kind of giving in to mediocrity, or the fact that they're poor performing, or that they don't give a crap. No, that's not acceptable either. But we want to truly come alongside them and say, hey, let's work together, and have them join us in what we're trying to do, because that's so important. I mean, how did any of us get where we are today? We obviously had a mentor, or we obviously had somebody that, took us under their wing when we first became ER nurses. I know I did. So I hope you do too. I hate looking down. I'm looking there, and the little camera's up here. Hi. And I hate that I have a glare on my glasses right now. I'm so blind. I need to figure something out. I have contacts in, and then I can't see close up, which sucks. So if you get a chance to put some comments in the chat for me about what you'd like to see, please, please, please do that. And if you catch this video and would like to subscribe, I would be so forever grateful. I really would love to first get to my first 100 subscribers, because I swear to God, you guys are going to be my ride or die. I know that my first subscribers are going to be the people that are like, they're my posse. They're my homies. And I want those people to ride this journey along with me, because I think this is going to get a lot bigger. And I know that the people that come alongside me now will be with me forever. So I really hope that you enjoy the channel and watch me fumble and curse and figure out this tech and how I'm going to put it all together. But I'm really trying, I promise. I am really trying. And if you saw this, I should let you see the cord mess that's all abound right now. My house is a disaster. I was looking for that one little cord that goes in from the microphone. It's over here. I have this really cool studio mic, and the end of the cord is this. And so there's a little jack that goes into that, and it goes into the USB-C. So it's a TCR into a USB. This would come out, and it would go in here, and this would go in the computer. So super bummed that it wasn't there today, and well, shit. Anyway, figure it out. The lighting got all screwed up as I was talking. I wish there was at least one person here. Hello into the YouTubeverse. Anybody want to say hello? Guess I'm not that interesting. Well, we will probably close it down. I've been gabbing on here for about 30 minutes, and maybe I'll just toss it on up on the regular stream. Just remember what I said. If you want to be an ER nurse, you will be an ER nurse. You just got to get yourself floated down there, get people to know you, be willing to do anything to help out. Make your name needs to be known. Let people get to know you. If you're willing to work hard, they'll see that. And the next open position, I guarantee you'll be thought of as that person. So just keep putting your foot in the door. And if it's closed on you, pull the manager aside one day and say, hey, when you have overflow, can you call me in to help? I'd like to help you with that. They love that shit. Call them up and see if they can put you on call to come in and help when they have overflow beds. I mean, if you want to be noticed, that's about the best way to do it, because when you become a savior, when they're in a crisis and in a bind, they remember you. Trust me, they remember you. I remember you. So I hope that helps. Brush up on your ACLS, BLS, and PALS. Make sure you are certified. I say that all the time. Any nurse who comes to the ER, please go get your ACLS, BLS, and PALS. There's no reason to wait for it. You don't even need to be an RN to do it. So just get it done. Tuck it under your belt. Most hospitals will pay you to do it. You get CEU credits for it. Go bite the bullet. And above all, it's okay to feel uncomfortable, because being uncomfortable is growth. And if you're uncomfortable just a little, you're growing in your practice and in your craft. So as far as I can say, you got this, and I'm here to support you. So I hope that you'll keep coming back and check out my videos and let me know what you'd like to see. And, I'd even love to get on here sometime with several nurses, and we can talk story time, see what other people are doing. What are you doing in your hospital? What am I doing in my hospital? I want to know what, just kind of trade stories, because it helps us to make the world a little smaller. Because, we might have 5 hospitals in a 3-mile radius here, and our boundaries never cross. But it's nice to know what kind of tech and what kind of processes are being used in other hospitals, because that sharing of data is how we learn how to incorporate more proficient, lines of treatment on how we can take care of our patients. So it's sharing of information. And, it's also a place of support here. We will not tolerate hate speech. There will not be any bullying in these rooms as we go forward. I'm just putting the groundwork out now. This is for educational purposes only. This is not for medical diagnosis. This is not an ask a nurse. We can ask each other questions about the practice, but this is not a ask a nurse, self-diagnose yourself kind of thing. You have plenty of that on Google. This is not the place for that. So if you are a nurse and you're working and you would like to ask questions, then this is a place for us to banter. So that's it for tonight, folks. So I'm going to try to maybe do another live tomorrow. I'm going to try to start shooting videos out more frequently. I've got, like I said, I have pages of content I have written out on all these items I want to hit. So I will shoot some videos, or I'll go on live, and the lives will be posted down on the replay. So you will see the lives on the replay. And if you put comments in the replay, I will get to them. So if you need anything from me, let me know. I also have an email at grassrootsrn@gmail.com. I'm found there. I am on TikTok. I am on Twitter. I am on Instagram. So let me know what you want to hear. If you're interested in NCLEX stuff and you want some help working on that and what you can do, maybe we can work out some lives for that too. So I'm here for you, babies. Anyway, I am going to shut this down for tonight. I hope you had a wonderful Halloween and that it's uneventful. And may God bless you and your family. I hope your bandwidth withstood this little live. All right. Good night.